Okay, so hello everyone. We will slowly start our meeting and I see the people are joining, so we will start not to prolong. And today we will talk about adult ADHD, so diagnosis and management. And we have a special guest. Hello, Dr. Leon Różewicz.
Hello.
And I will give you a brief introduction. So Dr. Leon is a consultant psychiatrist in London. He is an adult ADHD specialist. And in 2007, he established one of the first adult attention hyperactivity disorder clinic in UK. And now he's on training committee of the UK Adult ADHD Network and gives talks about an adult ADHD to GPs and consultants and to us today. And he also currently teaches medical students from UCL, University College London, and also a medical director of the Priory North London Hospital. So welcome again, Doctor, and it's a great pleasure to have you here. So I will not prolong this introduction, and the floor is yours.
Okay, thank you. Okay. Ja będę wykładał po angielsku, ale mogę powiedzieć kilka słów po polsku na początek. Mój techniczny polski nie jest wystarczająco dobry, żeby dać wykład po polsku i to bardzo przepraszam Państwa. To jest mój szpital w Londynie, gdzie ja pracuję, nazywa się Priory. To jest prywatny szpital psychiatryczny na północy Londynu. I to jest Londyn. Widzicie, jest dużo budynków z biurami i teraz nikt nie wie, czy ludzie kiedykolwiek wrócą do tych biur. Mam nadzieję, że tak, ale nie można na razie powiedzieć. Ja się urodziłem w Bytomiu i wyjechałem z Bytomia, jak miałem przeszło 7 lat. Jak ja mieszkałem w Bytomiu, to były wszystkie tramwaje tak wyglądały. Ja rozumiem, że jeszcze jeden tramwaj dalej tak wygląda w Bytomiu, ale większość innych tramwajów wyglądają inaczej. Ja rozumiem, że większość ludzi na tym wykładzie są ze Szkoły Medycznej Śląskiej w Katowicach i to jest, gdzie moja mama studiowała medycynę tak samo. To dla mnie jest wielki zaszczyt, że wykładać studentom z Katowic. Okej, a teraz będę mówił po angielsku. What is ADHD? That's the first question, really. By the way, I would like you to give me as many questions as possible. One of the problems of lecturing on Zoom is that it's very difficult to know who is listening out there, or if anyone at all is listening out there. And one way I've got of seeing that people are listening is if people ask questions. So please post questions on the chat function of Zoom, and I'll do my best to answer them at appropriate points during the talk. Okay, so what is ADHD? The first thing to say, it's a common neurodevelopmental disorder. We'll find out later exactly how common. It's associated with significant adult psychopathology. So when I was at medical school in the 1980s, I was told that ADHD is only something which affected children. In adult ADHD didn't seem to exist at the time. And over the past 20, 30 years, adult ADHD has been increasingly recognized as a very real illness. So symptoms are present in childhood and often persist. There is significant impairment. It is often associated with comorbidity, and by comorbidity, I mean other psychiatric disorders. And again, we'll cover why. It is often confused with other psychiatric disorders. It's a valid diagnosis. So we in the UK, I don't know what the situation in Poland is, but in the UK, there are a lot of doctors who think that ADHD doesn't exist. And in the good old days, when I used to give this talk in a lecture theatre and I could see people opposite me, and when I described the symptoms, people used to laugh. And you may ask, why did they laugh? Well, they laugh because people recognize a lot of the symptoms in themselves. And that leads to some people to believe it's not a real disorder. But as I'll go on to show, all of us have a blood pressure, but not all of us are hypertensive. All of us have a blood sugar, but not all of us are diabetic. So similarly with ADHD, it is actually the quantity of the symptoms and the severity of the symptoms which makes the diagnosis, rather than the existence of the symptoms themselves. So we'll go on to discuss the diagnostic criteria, and I'll explain exactly how many symptoms you need first to make a diagnosis. And the really good news is that ADHD is a treatable condition with evidence-based guidelines. So, as has been mentioned in the introduction, I started seeing ADHD patients in 2007. And in those days in London, which is a city of about 10 million people, there was only one ADHD clinic in one hospital in South London, which couldn't take all the ADHD patients who were there. And I was working in a different part of London. That was in South London. I was working in North London. And to drive from North London to South London can take 2 hours. I know it's one city. But it probably takes longer than driving from Katowice to Krakow. So it was difficult for my patients in North London to access the clinic. So I thought I'd open up a clinic. But in those days, there was almost no guidelines. Since then, there's been a lot of evidence-based guidelines in the UK and in Europe. And probably the best of these is the European Consensus Statement on diagnosing and treating of adult ADHD. There's a more up-to-date version of it now, which has been published in 2018. That's available free online. It's BMC Psychiatry. Everyone can freely access it and download it. These are the guidelines of the British Association of Psychopharmacology. They're also available freely online. And we also have something called NICE in the UK, which is NICE stands for National Institute of Clinical Healthcare Excellence. And they provide guidelines on the treating of every condition in medicine, not just psychiatry, but on treating everything. And they've published a very comprehensive guideline back in 2008, which is still really probably the best textbook on one of the best textbooks there is on ADHD, because it covers every single aspect. And again, that's available freely on the NICE website. So ADHD represents the extreme of a highly heritable quantitative trait. So it's highly heritable because, as you will see, it's caused by multiple genes of small effect. There are very few specific causes, and it is an extreme. So you'll see that a lot of people have some symptoms, but at some point you reach the diagnostic threshold, and there's the people to the right of this that have ADHD. And you could draw a similar graph for many other traits that we look after in medicine. I mean, blood pressure and blood sugar are one particular example where we have a cutoff that we call pathological at some point. So this is looking at the genetics really, and there are 12 independent loci that are related to ADHD, and it is a highly heritable condition. So when I diagnose adults with ADHD, I tell them that 30% of the chance of of any of their children having ADHD is 30%. So the chance of each of their children having ADHD is 30%. And when I diagnose children, in children, the chance of having a parent with ADHD is 15%, 1-5. And quite often, a lot of adults come to my clinic. I only deal with adults, by the way. I only look at people with patients over 18. So when adults come into my clinic, they quite often say that their child's been diagnosed, and they have a lot of the problems themselves, and they wonder if they've got ADHD, and they would like me to assess them. So it is a very, very heritable condition. There aren't many environmental factors that cause ADHD. Although I think childhood deprivation is one such factor. So one of the most powerful studies about environmental causes of ADHD looked at Romanian orphans. So there are Romanian orphans which came to the UK really at the end of the Ceausescu regime, and when they compared those orphans who were brought up by UK families with control orphans who were kept in Romanian orphanages, they found that the probability of ADHD in a Romanian orphanage, of those in the orphanages, was much higher. And the conclusion they've reached was that there was something about maternal deprivation in childhood, which was an important causative factor of ADHD. And they did also control for the fact that those children that were selected by their adoptive parents may have had fewer traits of ADHD in the first place. So that was controlled for. But nevertheless, there was an upbringing effect, which was quite powerful. But the message I want you to take from this talk, that it is mainly that the most important factors in causation of ADHD are genetic ones as opposed to environmental ones. Okay, so the worldwide prevalence of ADHD in children is around 5%. It doesn't matter much where you look at. So the studies that have the broader confidence intervals and are out here are the smaller studies, or where there are fewer studies. But where there are a lot of studies, it tends to cluster at about 5%. And again, so what happens as you grow up? This is a 2015 UK study. So what they find, and so what they've looked at, they followed up children for a mean of 6 years between the ages of 14 and 24. So what they found was that around 80% of these children still retained the full diagnostic criteria at 24. And obviously 60% of the combined subtype, combined being attentive or hyperactive, 32% were inattentive, and 8 were hyperactive. But this is the column which is the most important one, really. So what's the prevalence of adult ADHD? So the evidence is that some children do grow out of it. It's not 100%. So the prevalence of adult ADHD tends to cluster at around 2.5% of the population. I think that figure is a bit low. I think 3%, maybe 3% probably be more realistic. So it's lower than that in children, but it is a very significant figure nevertheless. So sex differences, that's quite interesting as well. So in children, you get a lot more males than females. In my clinic, it's about 50-50 actually. And the question is why? Why is it different in adults and in children? And I think the reason is that boys tend to be naughty. So boys with ADHD tend to be aggressive, more difficult to manage in class, so they're picked up by teachers. Quite often girls with ADHD sit in the back of the class and don't pay attention and dream. They tend to be less behaviorally disturbed. And that's why they don't get picked up till adult life, when they go to university and the whole system breaks down. So that's why in my clinic, it's 50-50, but in childhood, boys present more often, simply because they're the ones who are more difficult to manage at school. Now, what are the brain mechanisms of ADHD? It's quite a complicated slide, and I'm sorry for this, but essentially there are several ways of looking at the brain in ADHD. So the important areas are the parietal cortex, the dorsolateral prefrontal cortex is probably the key, and the ventromedial prefrontal cortex. There's something called the default mode network, which is very important, and I'll talk about that later. The reward circuits are very important. So I think one key principle of ADHD, people tend to think that people with ADHD don't pay attention. And that's actually not true. And the reason why it's not true is because they're very good at paying attention to things they're interested in. So if you've got someone with ADHD who is interested in something, they'll hyper focus. Okay? They will pay more attention than they need to, and they will not be able to pay attention to their environment. I'll explain that a little bit more. So you get a lot of people with ADHD who are interested in computer games, and somebody might say, well, look, he's brilliant at computer games, he can't have ADHD because he can really concentrate on that. He can spend 8 hours in front of the computer playing computer games. But the reality of it is that they find that if interested in it, and they can hyper focus. If people are not interested in something, then it's boring, and they can't pay attention to that at all. And you will hear what happens instead later on in my talk. So I usually say that people with ADHD are very good if you put a gun to their head. So if you've got if you've got a task with a short deadline, the person with ADHD is the guy to do it, because they will be very good at focus. They will ignore everything else that goes on in the world. You know, they'll ignore their children, they'll ignore their friends, they'll ignore their romantic partner. They'll just get on with the task because there is a deadline. And if the deadline has to be met, they will do it. And the reason is that they've got a deficient reward circuit. So, sorry. So they're very good at doing tasks which got a high reward, but completely hopeless at tasks with a low reward. And if they're interested in something, or if you stick a gun behind their head, then that's a high reward task. And the pathways involve noradrenaline and dopamine, because there are the neurotransmitters involved. And it's the pathways here from here in the midbrain to the frontal lobes where the dopamine flows. And I'll explain a little bit more about that later as the talk goes on. So Thomas Brown, who's an American psychologist, thinks of ADHD as a deficiency of executive function. And executive function is the part of our brain which works in the frontal lobe, and it's about planning, organizing, prioritizing, and also it's about inhibition. So it's about managing frustration, about irritability, and also involves working memory. And people with ADHD have problems with all that, as I'll go on to explain. So executive functions are very deficient, and they are the bits which are in the frontal lobes of the brain. And there's also the default mode network. Now, the default mode network is very interesting, because the default mode network is that part of the brain that's alert to our environment. So I hope that all you people are listening to my lecture. But there may be other things going on in your environment. I don't know if you're at home or whether you probably are at home, I assume. And there may be other things. Some of you might have children, might have relatives. There may be other things going on. And the default mode network is that bit which, although you're listening to my lecture, you can be alert to what goes on outside. So if there was an emergency at home, or if somebody wanted your attention, you might be able to stop listening to the lecture and say, hey, look, Is this essential? Do I stop now? I need to stop listening to this lecture because there's something more important. So if you think of the guy who's playing computer games for 8 hours a day, there may be other things going on with his life, like a need to eat, they need to socialize, maybe they need to focus on the children. And most of us would be able to detach ourselves from the computer game and focus on that. And that's the default mode network, which scans the environment and looks for other cues. Now in ADHD, the default mode network is deactivated because when you're focusing on something really important, and therefore you can't pay attention to your environment. So what I really want you to think about is not an ADHD as a disorder of attention, but it's a disorder of switching attention from things which seem really important to things which might be less important. And it's the switching that's actually deficient in ADHD. And this is quite a nice little study. This is a functional MRI study which looks at a default network activation. And what it does, it compares people with a low incentive task and a high incentive task. So if you look at these, I mean, at these graphs, so these are subtraction images which compare the activation of people with ADHD to controls. So if you have an ADHD patient who is off methylphenidate, you will see that if you give them a high incentive task, they're actually better than the controls, yeah? They're actually better at doing that than the controls. This goes further. But if you give them a low incentive task, something which is very boring and routine, maybe like doing a form, doing a boring spreadsheet, doing something that's completely tedious, the control person is probably as good, if not better, than the high incentive task, but this guy can't do it. Now, once you give methylphenidate, what you actually see, they become as good in the low incentive task as the control. They actually become slightly less good than the high incentive tasks, but probably still good enough. And that's actually a very neat study to illustrate the problem. And I think if there's one lesson I want you to take from all that, if there's one thing you remember is that if somebody turns up in your clinic and they say, oh, he's brilliant at focusing on his work, but ignores the family, or he can focus on one particular aspect of work which is interesting, but doesn't do the boring things, it doesn't mean that they don't have ADHD. He's very good at computer games. Of all the patients that I saw, the best illustration of that came from a student that I saw many years ago now. And this guy was studying at one of the best universities in the UK. I can't remember if it was Oxford or Cambridge, but it was one of those two. And he was the captain of the chess team, okay? Captain of the chess team. Now, you would have thought that to be a captain of a chess team of a top university, you have to be very good at chess. And indeed, he was very good at chess. And you would have thought that chess isn't a sport for people with ADHD because you have to think a few moves in advance, you have to really concentrate. I mean, people who are good at chess think 5, 6, 7 moves in advance. They memorize a lot of games. And you'd have thought somebody with ADHD wouldn't be able to do that. But this guy was able to focus on chess. But when it came to doing his studies, you know, what he was actually at university for, couldn't do it. He would take, I don't know if any of you have been to Oxford or Cambridge, but there are these wonderful colleges with a lot of fields outside. You know, each college has got a huge field at the back, and usually a river where we can go for walks and play rugby or whatever else that you do. And he couldn't concentrate in his college room because there were too many distractions. So he would pitch a tent in the field, and he could only concentrate in the tent where there were no distractions. But yet he was brilliant at chess. Now, somebody might have thought, if you're good at chess, you can't have ADHD. Not true. This is just what I've actually said, really, that methylphenidate normalizes the reward pathways. And medication allows someone with ADHD to function in a low salient environment so they can do the boring and rewarding things. Okay, so let's talk about the definitions. So in ICD-10 had a very restrictive definition of ADHD. You had to be very hyperactive there is no ADHD in ICD-10. It used to be called hyperactive hyperkinetic disorder, and you had to be really hyperactive. So ICD-10 will only catch the extreme of ADHD. In ICD-11, the definition is much more like the American DSM, and it's characterized by a persistent pattern of inattention or hyperactivity, impulsivity, with onset during the developmental period. So there has to be a childhood onset, typically in early to mid-childhood, and the degree of inattention hyperactivity is outside the limits of normal variation, okay? So it's about that curve which I showed earlier. It's on the right of the curve. It's outside the limits of normal variation. And it has to significantly interfere with academic, occupational, and social functioning. So there has to be significant impairment. Now, when I diagnose ADHD, I use the DSM-5 criteria because the DSM-5 criteria tell you what the symptoms are, and you can very simply go through its symptoms and work out whether the patient meets the criteria. So there are 9 symptoms of inattention: lack of attention to detail, making careless mistakes, that's 1. So is the kind of person who will make a lot of spelling mistakes, maybe will miss out bits of a form, will do an exam but will miss out half a page because they just miss it. Difficulty in sustaining attention, so they start things which they don't finish, okay? So quite often they will start watching a movie but will not finish. Or if you give them some very boring task like painting a wall, they might start painting the wall but will never get done because something else more important will happen. If you tell them to tidy a room, they will start but they will never finish. And often it's a story of a lot of projects in their life which they start, a lot of things they want to do, but they never quite get around to doing. So they'll start learning a language and they'll get very enthusiastic about it and then it will stop. Or start learning a musical instrument and they'll be very enthusiastic for the first few weeks, but then it will not go any further. Does not listen when spoken to directly. So relatives will often complain that they will be telling them to do something like, so the partner will say, we're going out in 2 days to see so-and-so. We're doing this in 2 days' time. Well, that was in the days when we used to do things. We all stopped doing things because of COVID now, but the days when we used to do things, that's what would happen. And the person will say, yes, I'm going to do this with you. And then they forget and they will say, well, next day they will say, what are we doing on Saturday? And they just didn't take it in. They also have trouble in completing and finishing jobs or tasks. But the other problem is they don't follow instructions. If you give them written instructions, people with ADHD will not follow instructions because it's too boring. It's much more interesting to do things in an intuitive way. They have difficulties in organizing tasks and activities. They're often late. It's very difficult to manage time. So I usually say, how often are you late? And they will say, well, I'm late. I'm never on time because it takes me too long to get ready and I lose sense of time. I'm always 15 minutes late. Interestingly enough, the other thing they say is that I have to be half an hour early. If I'm half an hour early, I make sure I'm half an hour early and I'm never late. Or the other thing they say, I put my watch forward, so I think so everything always seems later than it is, and that makes me on time. So if I think that the time is half an hour later, I'll actually be there on time. And this business F, avoiding or disliking sustained mental effort, that means that they procrastinate. So something is very difficult, they'll put it off. So I'll usually say, when do you do things? If I gave you a task with a deadline. When would you do things? Lots of people with ADHD would say, I'll start doing it the day before the deadline. I'll be up all night because then I know I have to do it. But if I start 2 weeks later, 2 weeks earlier, I won't do it because it's not interesting enough. It can wait. And things that can wait are paying bills, doing a tax return, writing letters, writing emails. It can all wait till the last minute. And in English, we say they procrastinate. So I don't know what procrastinate is in Polish, I'm sorry. But they put things off and put things off and put things off. And they'll often work all night. And a deadline puts, I talked about putting a gun at the back of your head. And a deadline puts a gun at the back of your head. If a deadline means you will not get a university degree because you have to finish the project on time, or you'll get fired from work because you don't come up with the goods, that's the time to do things. And they can then hyper-focus and get it done. They lose and misplace things. So they're often looking for things like credit cards, mobile phones, glasses, and sometimes they lose them, but quite often they misplace them. And in childhood, they're the kind of child who keeps leaving bits of sports gear at school. People with ADHD are easily distracted. So I know that they will often ignore what goes on outside, but if they're doing something boring, something will be more interesting. So quite often they'll say they'll be working on their computer, trying to do university work or school work, and they'll be distracted by the emails that come in, or by the texts that come in on the phone, or by Facebook or Twitter, or whatever else that they do. And they're also forgetful in daily activities, so they forget things. Now, somebody asked if you need all 9 of those. The answer is you need 5, so 5 or more are enough. So you will see that I'm going to move on to symptoms of hyperactivity and inattention. So you need 5 out of 9 symptoms of inattention, so you need 5 out of 9 of those, or 5 out of 9 of the hyperactivity impulsivity symptoms. So there are 6 symptoms of hyperactivity, 3 of impulsivity. So the activity, so there's fidgetiness, they can't keep still, they move their hands and feet all the time, or they will play with their headphone cord or with the pen, or they will twiddle the pen, or they'll bite their nails, or, they just can't keep still. And also they find it very difficult to sit down, so they find it difficult to stay in lectures because they have to stand up all the time. So I usually ask people, do you prefer sitting or standing? They can also be restless or overactive. There's inner restlessness. They find it, in terms of hobbies, they find it very difficult to do quiet hobbies. So they like to do sports, going to the gym, and they're always on the go. So the friends think they're very, very energetic. And the other feature is that they often talk too much and talk too loudly. Now, in terms of impulsivity, we often say in English that they lack a filter. So they will blurt out answers before, they will say things to people before thinking about them. So they'll go out with a group of friends and somebody will wear the wrong thing. Now most of us wouldn't comment on it. But somebody would say, oh, you really don't look right. And the person with ADHD will say this and then immediately regret it. But they haven't thought what they were going to say through. They haven't thought about it. They haven't filtered it. They find it very difficult to wait in queues. So they'll go to the supermarket and they will abandon the trolley in the queue if there's a long queue because they don't like waiting. Some people say they can cope with waiting if they spend all the time on their phone when they're waiting. So mobile phones really help with this. They also have difficulties in driving for that reason, because driving is about waiting in queues. So what they will do is they will quite often get a lot of points for the speeding, penalty points for the speeding, or they'll be involved in road traffic accidents. And they also interrupt other people's conversations. If they need to say something, they need to say it now. It's more important than the other person has got to say, so they'll barge in on a conversation. Or they're worried that they might forget to say it. Or they are bored of the conversation, and therefore they want to change the topic. So for all those reasons, they interrupt conversations. And again, you need at least 5 out of those symptoms. So if you have 5 out of the inattention symptoms, you have inattentive ADHD. If you have 5 or more out of the hyperactive impulsive symptoms, you have hyperactive ADHD, and you have 5 or more in both groups, you have combined ADHD. Now, we're very careful that the diagnosis isn't just about counting symptoms. So there are 2 other features which are needed for the diagnosis. You need to have a history of childhood symptoms. You need to establish that some symptoms are present before the age of 12. Incidentally, that might actually be changing now. That is the case in DSM-5. It is the case in ICD-11. But over the past 1 or 2 years, there have been a number of papers, a number of very big cohort studies, which have shown that you can diagnose ADHD in adults who've had no symptoms in childhood. And they're very good at doing this in Scandinavia for some reason, where they follow people, they were very good at having population registries where they follow people up. So some of these population registries show that people have convincingly diagnosed ADHD in adults, but when these people were seen as children, there was no ADHD. So that's interesting, and that changes our concept of ADHD, but I don't want to talk too much about that because that's something that could become more I suspect there'll be more research into it. So as things stand today when we speak, you need to have some symptoms before the age of 12. And you also need to have impairment in more than one domain. And the domains are work function, social relationships, coping with daily activities, driving accidents, behavioral problems. So you need to have more than one domain. So strictly speaking, if the problem is only at work, it's not ADHD. But if it's work plus social plus driving, that meets the criteria. So you need to have more than one area that's impaired. In addition, you need to look for distress from the symptoms, low self-esteem. People with ADHD very often have low self-esteem, emotional liability, and sleep problems. I'll talk about comorbidities a little bit later. Okay. So how do we assess ADHD? So what we do in the UK and in the US actually is that there is no specific diagnostic test, and we don't go in for psychological testing. We simply take a very detailed psychiatric history, a family history. We look for comorbidities, and we also take a very detailed developmental history. And we really ask a lot about what happened in childhood. So I usually spend 2 hours assessing a patient with ADHD. So I start off by asking what the main problems are. I assess for depression, anxiety, any other psychiatric illness. I take drug, alcohol, and addiction history. I take a personal and developmental history about birth and developmental delays. And I usually like to speak to an informant as well. So I like to get a history from a parent or a romantic partner. I quite often ask what was in the school reports. So it's a very, very detailed history of somebody throughout life. And then I use the Diva II, which is a standard, it's a semi-structured psychiatric interview, which goes through each of the 18 symptoms. I'm afraid I haven't got time to go into the details of the Diva, but it is a very, very good standardized way. So when I talk about the symptoms, every single person that I ask more or less the same questions. And therefore, by the end of my 2-hour assessment, I know whether there were childhood symptoms, whether there are current symptoms, and what areas of life the symptoms are affecting. And I also would have found out about any other psychiatric problems. The Diva is a free, there's now a Diva 5, which looks at DSM-5 criteria. It's available to download, I think, very cheaply. I think it's about 10 euros. And once you download it once, you can use it on as many patients as you want. And there is a Polish version. So there is a Polish version of the Diva. If you go to the Diva website, you will find the Polish version. And I think it's about 10 euro to download. And then you can use it as many times as you like and as many patients as you want. so you don't need to pay per patient that you use it on. There are other semi-structured instruments that they're all pretty similar, but I tend to use the Diva because it's free and it's very standardized and very easy to use, and I think it's available in many, many languages. So I think for Poland it's perfect because there is a Polish version. Okay, I think I'd like to cover the questions now that we got so far, and then we'll continue with the rest of the lectures. I can see the questions here. I think I've answered one of them about how many symptoms. The other one, how can prevalence in adults is less than in children? The condition is hereditary. So the reason why prevalence in adults is less than in children is because some children go out of it. So by the time they get to be adults, then they no longer meet the criteria. I did say it's probably about 20–30%, so it's not many, but that's the reason why it's less. Okay, are there any more questions at this stage?
I have additional questions. So I have questions regarding those cases from Scandinavia with adult ADHD, and do they hypothesize regarding to the causes of this ADHD, adult ADHD, without these symptoms in childhood?
Well, I think they just talk about people having ADHD, but nobody picking it up. And again, once you get into the question of retrospective, because you see, if I see somebody who's 30 or 40, it's very, very retrospective, and the patient may not remember what childhood was like, the parent may not remember. As people get older, it's more difficult to talk to the parents because people are much more reluctant to bring them into consultations for understandable reasons. So you may not be able to pick it up. And I think I've got a slide which talks a little bit more about what happens with development. Actually, I'm not sure I put that slide in. Sorry. But the other thing that tends to happen is that we talk about scaffolding. Again, I don't know what the Polish for scaffolding is, but scaffolding is the thing you put. If you're building a building, you start off by putting some scaffolding which holds the building up before all the bricks are there. And the reason why that's quite a good analogy what goes on in ADHD, because when you have a child, your parents do a lot for you, and some parents do more than others. So in England, some parents are so competitive that they'll make sure that the child goes to school. They go to a school where the school tells them exactly what to learn. They come home, the parents make sure they make the homework every night. They even sit with the child and do the homework. And sometimes this goes on until they're 18. When they go to university in England, there is no structure. And suddenly, you know, they discover alcohol, drugs, sex, and the whole structure of studying disappears. So remember when my son started university many years ago, he phoned me in the first week and said, "Hey, I didn't know that you could go out during the week. You could go out every night at university. You could party every night." And this was the most important thing about being at university. And obviously, once you start, and also the style of the teaching at university is that you're left to do much more yourself. So if you've got ADHD and suddenly the structure is taken away from you, and you have to create your own structure, a person with ADHD can't do this. They can't organize their studies themselves. And they'll present with ADHD in the first year at university. And suddenly you have a student that was perfect at school, was the top of his class, is the bottom of the class at university because mom and dad are no longer there to organize them. Any other questions?
So I have another question. When it comes to, is there a downside, a darker side to this hyperactivity and hyperfocus? So these individuals, they can hyperfocus on one task, but is there a burnout then the day after?
Well, the downside is that all of us, and any job that you might want to do, there are good bits which excite us and very boring bits. So as a psychiatrist, I love being with patients. I hate writing reports about them afterwards, I hate writing letters. But to be a successful psychiatrist, I have to do a lot of letters, a lot of paperwork. And if I couldn't do that, I wouldn't be able to do my job. And medicine's like that, if you are in any medical specialty, there are bits which are very exciting, other bits are very boring. And to be successful in any field, you have to manage the boring stuff. If you don't manage the boring stuff, you're no good at it. And that might apply to your relationships as well. If you spend 8 hours a day playing computer games, you're not very much fun for your partner, are you? Your partner's going to get very bored with that. So you don't pay attention to your partner, to your children, to everything else in life. So there's a huge downside, yes. Anything else? Any other questions?
So I think we have no more questions for this part. Oh, we have. So is it possible to diagnose correctly adult ADHD during the first appointment? You've mentioned that you spend around 2 hours with patient discussing his history. Is it enough? What other illness is similar to adult ADHD and can be mistaken with?
Okay. So it is enough for me, yes. Sometimes it isn't. Maybe in 1 or 2% of patients ask them to come back. But generally speaking, it's enough. There are many illnesses which can be mistaken, particularly bipolar disorder, emotionally unstable personality disorder, drug misuse, which I'll talk about a little bit later, can cause difficulties. But obviously, my 2 hours are focused on looking at these different illnesses and seeing the difference. For example, with bipolar disorder, ADHD is a trait, not a state. So people with ADHD will be the same all the time. People with bipolar disorder will be hyperactive during the times that they're manic, but at other times they won't be hyperactive at all. So people with ADHD are hyperactive all the time. I'm afraid I could give you another hour lecture on how to differentiate this. And because we've got a very short period of time, I can't cover it all. But the answer is that yes, you have to think of other disorders. And again, I don't know what Polish psychiatrists do, but I spend an hour for everyone else. So my usual assessment of somebody with depression or anxiety is 1 hour. With ADHD, I take 2, just to make sure I've got it right. Now, there's a very complicated question here. Is it possible to induce ADHD symptoms by downregulating dopamine receptors with the use of hyperdopaminergic activities like scrolling in social media, further compulsivity, drugs, porn, high rewarding foods? I think the answer is yes, if you overstimulate people. But again, it's not going to be there all the time. It might be there. Certainly drugs can induce ADHD symptoms when you are high. If you've had several joints of cannabis, you can have very similar symptoms to ADHD. If you take stimulants like cocaine or MDMA, yes, but they're not there all the time. So again, state versus trait. So a trait is something that's there all your life, all the time on a background level. State is something which occurs for several hours. Okay, but look, like everything else in medicine, none of these things are perfect, and we get them wrong. And you have to be aware that, particularly in psychiatry, that you might have got things wrong, and you have to always be prepared to revise your diagnosis. Okay, let me talk a little bit about comorbidities now. I'm afraid I've still got quite a lot to cover, and I would like to talk about treatment as well. So ADHD and comorbidity. So, what this little diagram, what this diagram shows is that there are a lot of potential comorbidities with ADHD, and obviously I'll talk about some of those, and I'll try and give you a way of thinking about them. So there are overlapping neurodevelopmental disorders. So some neurodevelopmental disorders, like autism spectrum disorder, which used to be called Asperger, now it's called autism spectrum disorder. So 22% of those with ADHD have autism. So in my clinic, in my ADHD clinic, about 22% of people are going to have autism. And if you look at people with autism, about 41% have ADHD. So both disorders affect executive function, affect the frontal lobes of the brain. There's a huge overlap of dyslexia and dyspraxia. And there's also an overlap with tic disorders. So about 12% of adults with ADHD have tic disorders and 4% without. So these are overlapping conditions. Some of the genes may overlap, some of the parts of the brain may overlap. So that's one reason to have another comorbid disorder. Now, another reason is that having ADHD can itself cause a psychiatric disorder. And the reason for that is that if you're failing for the whole of your life, if you're not succeeding in life, everything's difficult. If you're failing at your job, at your relationship, you will be depressed. If you can never get things done on time, if you're constantly losing things and looking for things, you might be anxious. If you are impulsive, you might have antisocial personality disorder. You might have a borderline personality disorder if you're impulsive, because borderline personality disorder causes impulsivity. And also if you're impulsive, you might be inclined to use drugs and alcohol more, because as you know, these are impulse control disorders. So all those things are raised with ADHD. And if you want to find a lot of ADHD, people with ADHD, do you know which place you'll find more people with ADHD than anywhere else? Maybe some people can put that on the chat and see if we get this right. So what do you think the answer is? Which place are you going to find more people with ADHD than anywhere else? If you want to put that on the chat, some of you want to guess. Just to make it a bit, yes, thank you. Prison, perfect answer. So probably around 30% of people in prisons have ADHD. That's exactly right. Okay. And again, part of so quite often if you treat people with ADHD, you have to think of all these comorbidities. You can't ignore them. So a lot of my patients are both on ADHD medications and depression. I saw two patients this evening before giving this talk, and they're both people who were assessed about 6 weeks ago, and they were depressed as well as having ADHD. And they both said that their mood has significantly improved with medication, because now they can actually manage the tasks which they couldn't manage before. So in that way, treating ADHD is very rewarding. Okay, so this just really talks about the ADHD. SUD is substance use disorder. So it's a response. So why do people with ADHD use substances? Impulsivity. Some self-medicate, so quite often people say that cannabis makes them less hyperactive. Response to negative life experiences. And does it go the other way? So that's the question that somebody asked earlier. Can using substances induce a hypodopaminergic state, which causes ADHD? Not true ADHD. It's something which may look similar to ADHD, hence the question mark. And obviously other stuff, environmental factors can cause both. So we know that people who grow up in environmentally deprived households are more likely to use drugs, and there may be some genes as well involved. So that's the. Okay. Any questions about the comorbidity before I go on to talk about treatment?
I see no questions in the chat, so maybe they will appear later on.
Okay. Am I speaking too quickly? Can people understand me? Can people just give me some feedback?
I think the speed is great. And if yes, like Mikołaj writes, yes. Yeah. So
okay, people want me to slow down. I'm happy to slow down. Okay, let's keep going. So the treatment for ADHD, there are really three domains of treatment, okay? So I'm mainly interested in medication, and I'll explain why, but there's also psychological treatments and psychoeducation lifestyle modifications. Now, in children, generally the approach is to start with psychological treatments first. So in children, what we usually start with is family interventions, cognitive behavior therapy. Now, in adults, the evidence of psychological treatments work are pretty weak. So the NICE guidelines say that psychological treatment should be second line. And there are two types of psychological treatments. There is treatments delivered by formally trained psychologists, which would be cognitive behavior therapy and mindfulness. There's also coaching, and ADHD coaches are not really psychologists. They're often people with ADHD who have gone on a course, usually in the United States, to become ADHD coaches. And some of them can actually be very good with patients. So don't really dismiss coaching as an intervention. But in terms of evidence, there isn't a great deal of evidence for psychological interventions. I mean, psychoeducation is very important. So usually, as part of my 2-hour assessment, I will probably spend at the end of the assessment, probably 15, 20 minutes, explaining to people what ADHD is, talking about dopamine in the frontal lobes of the brain. I'll recommend books, websites, all that kind of thing. And there's also lifestyle modification, but to be fair, most people, by the time they get to see me, they've tried various modifications. But medication is probably the most evidence-based treatment for ADHD. And about 80% of patients improve with medication. And my specialty is really using medication for ADHD. That's what I do. I do work with psychologists and occasionally refer people for psychologists, but a lot of my patients can't actually afford to pay for the psychologist. And in the UK, the healthcare system, the NHS, is not very good at paying for psychological interventions for ADHD. So I do run a free ADHD clinic as part of the NHS, but I don't have any access to psychology there. So this illustrates the dopaminergic dysfunction in ADHD. And what this slide shows, again, these are actually PET scans, and the scans result from actually subtracting the controls from the patients. And what this shows is that there is reduced dopaminergic function in the putamen, the amygdala, and the right dorsal midbrain. And this is 3,4-hydroxyfluorphenylalanine, F-dopa, which is a PET marker for dopamine. So our treatment is really based on the dopamine hypothesis of ADHD. And it is a hypothesis because we don't have any direct evidence about it. So stimulants and non-stimulants, such as bupropion and tamoxifen, increase synaptic dopamine levels in the brain and improve ADHD symptoms. And stimulants do it directly, non-stimulants do it indirectly. Now, dopamine modulates reward in the ventral striatum. It tells the brain when reward is particularly salient. Now, there are two types of dopamine circuits in the brain. There are the tonic circuits, which fire all the time, and there are the reward circuits, which only fire when we do a high reward tasks. So the reward circuits in people with ADHD are as good as anybody else, but they've got a reduction in dopamine firing, dopamine neuron firing, in the tonic circuits, which give you the background level, and that's why the boring tasks they're not so good at, but the reward tasks they're as good at. And also dopamine modulates working memory and also frontal inhibition. So frontal inhibition is the bit that stops you from making a stupid or inappropriate comment. And if you have reduced frontal inhibitions, if you have reduced frontal inhibition, you're more likely to say things which you regret saying, or indeed you're more likely to be impulsive and you're more likely to maybe do impulsive things. And so that's number 4 just explains about the tonic background and phasic reward-based intermittent pulses. And ADHD patients have a reduced tonic pool of dopamine and noradrenaline, but they compensate with an increased phasic release, which is to do with reward and novelty seeking. That's to do with the high reward tasks. So this is your dopamine theory. Now, all the medications that we use relies on dopamine circuits. And this is simply the most up-to-date study in Lancet Psychiatry by Cortese, who's a psychiatrist working at the Maudsley Hospital in South London. And he did a very big meta-analysis. And essentially what this shows that the efficacy that the medications we use, amphetamines, atomoxetine, bupropion, methylphenidate, are better than control. So that all favors the active medication, but the medications are less tolerable than the controls, which again what you'd expect, because unfortunately all medications have adverse effects. So none of these medications are perfect, as no medication is. So if you look at the tolerability, that favors placebo. If you look at the efficacy, that favors the drug. And you know, but this negative bit isn't really surprising. But I have to say that in my experience, because I'm a general psychiatrist, so I treat depression, psychosis, as well as treating ADHD, and the ADHD medications have far fewer adverse effects than, say, antidepressants, and even you talk about the modern antidepressants like sertraline and nafaxine. There are still ADHD medications. Still, patients are much better at tolerating them than depressed patients tolerate antidepressants. Okay, and sorry. And again, this is one of the perhaps earlier studies, which is a randomized placebo study of methylphenidate of adult ADHD, and you can see, I mean, you do get a placebo response, but the active response in terms of reduction in the score is much better. Okay, and again, similarly for atomoxetine, you know, again, the active drug is much better than the placebo. And if you look here at this study looks at various aspects of ADHD and whether they improve with medication. So if you look at injury, there's a reduction in injuries, reduction in road traffic accidents with medication, reduction in criminal behavior, even reduction in suicidality, substance misuse disorder. All those things tend to improve. Now, what this shows is the increase in prescribing for ADHD. As you can see, the US leads the way. Arguably, too many people get treated with ADHD in the US. It's quite interesting, actually, because I do get a lot of American patients in London. And I've talked about my assessment system, which involves 2 R's, carefully asking about symptoms. Now, I often see American patients who come to work in London and they come with their ADHD medications, and I try and see the original assessment. And the assessment is very, very brief. They haven't seen the psychiatrist for 2 hours. It's often just half an hour, and it's not nearly as thorough. And we do know that in the States, there's a very high rate of prescribing, which is perhaps excessive. I don't know where Poland is on this. We in the UK are here at the bottom, actually, in 2015. It might actually be increasing now, so we still don't prescribe very much. So I suspect the US is far too much, and we are far too little. And the correct prescribing would probably be somewhere here in the middle. Okay, my guess would be that Poland would be towards the bottom here, but I don't know, I might be wrong. Please let me know if I got that wrong. If any of you know better, please put that in the chat. Okay, this is the question. Again, one reason why people are very reluctant to prescribe medications for ADHD, because these medications are amphetamines, so they could be potentially addictive. And some people say if you start people on amphetamines, they will then go on to use other substances. So the question is, what is the outcome? And the outcome is that the best studies show that putting people on ADHD medication probably makes no difference. In my experience, I have a lot of people who use quite a lot of cannabis when they first come and see me, and what I see is a reduction in cannabis use in people with ADHD because they use cannabis to self-medicate. So actually, in my experience, is that treating ADHD reduces substance misuse. What this paper shows, which is much better in my experience, is that it makes no difference. It neither protects nor increases later substance misuse. The other issue is, do people get high from stimulant medication? Because in the UK, these are controlled drugs and you have to have special rules for prescribing them. They're quite difficult to get. A lot of doctors are not keen to prescribe them. I have to say, in nearly 15 years of prescribing for ADHD, I've not seen a single patient being addicted to this. And most of my patients, the first thing they say after they've tried the medication for a few weeks, do I have to take it every day, doctor? And most of my patients, the answer is no, you don't have to take it every day. So you don't have to take it at weekends if you don't want to take it at weekends because you're not working. You can choose when you take it. You can't take it every day, but you don't have to. Now, I put to you that if people are getting addicted to this, they'd want to take it every day. They'd want to take more and more. And again, I don't see this. People don't ask for more and more. Once you establish the right dose, it doesn't go up in years. I follow them up and it just doesn't go up. The number of people who want to take more and more, I can probably count in one hand. And again, why is it not addictive? And this is probably the best diagram. And to put it bluntly, ADHD medications are not fun. So if you take IV cocaine or you smoke cocaine, you get this hit and plasma level goes up straight away. That's fun. That gives you a high. If you inject amphetamine, that's fun. If you use, with ADHD medication, that's what you get. A very slow, boring increase. No fun at all. So that's why people don't become addicted. So the next question is, how would I deal with people who present with substance misuse? And again, I normally talk about this for about half an hour to an hour on my course. But to put it very quickly, I'm not going to go through the whole of this slide because our time is running out. And I want to leave some time for questions. But what I will say is that if people use a little bit of recreational drugs, if they have the occasional cocaine or the occasional cannabis, I've got no problem with that at all. I'm happy to treat them for ADHD. If they are heavy, uncontrolled users, I can't treat them for ADHD because I don't know how it's going to interact with my medication. I can't even assess if they've got ADHD because, as somebody pointed out, many of the symptoms overlap. So if people use recreational drugs in an uncontrolled way, I ask the substance misuse colleagues to see them first, get the drug use sorted out, and then to come back to me after that for an assessment and treatment. And some people fall between these two extremes, and then it's a question of using judgment, really, clinical judgment. So that's the answer to the drug use. So the efficacy of stimulants, methylphenethylamine, and non-stimulants, tamoxifen, has been demonstrated in many studies. There is some evidence for bupropion as a third-line option, and modafinil, again, it is used in the States, we don't use it in the UK. Stimulants have medium effect sizes, which are actually pretty good, 0.5 to 0.8%, and that's better than for most psychiatric medications. And non-stimulants have also pretty good effect sizes. These medications are very safe, and as I've already shown in a previous slide, it's not just about reducing symptoms, but reducing road traffic accidents, helping with at work, and generally improving function. Okay, so how do these medications work? So methylphenidate blocks the reuptake of dopamine and noradrenaline and blocks noradrenaline transporters. So essentially they increase noradrenaline and dopamine in the synapse. They may also increase dopamine and noradrenaline released into the synapse from the presynaptic nerve terminal, and they act on both the prefrontal cortex and the subcortical striatum. And you get a rapid increase in noradrenaline and dopamine, so you get an immediate effect. So people will say, when will methylphenidate start working? And my answer is, if I give you a big enough dose to work straight away, you'll know immediately. I usually don't give people a big enough dose at first because we have to titrate it. So I usually give them a very small dose, and I say, if it doesn't work, come back and see me and we'll increase the dose. So I usually say, I'll give you a small dose, we'll review things, and then we'll gradually increase the dose. And you know, so the act as releasing agents. And now these are amphetamines, which are not the synthetic amphetamines, methylphenidate. But again, these are predominantly as releasing agents. So I'm talking about dexamphetamine here. They stimulate the release of the dopamine and noradrenaline into the synapse. They also block reuptake. And like methylphenidate, they act in the prefrontal cortex, subcortical striatum, and they work straight away. So they're pretty similar to methylphenidate. Now, atomoxetine, that takes longer. So with atomoxetine and bupropion, well, so what atomoxetine do, it's a noradrenaline reuptake inhibitor. And what it then does is the noradrenaline gets converted to dopamine. It also blocks the noradrenaline transporter. It works only in the prefrontal cortex. But like antidepressant, the effect takes 2 to 4 weeks, and you have to take it every day. So atomoxetine, if you don't take it every day, it's not going to work. And you have to, but can take 2 to 4, even 6 weeks. So it's very similar to antidepressants in that respect. And why? Why does it work straight away? Because to exert its effect, it has to change both synaptic and presynaptic proteins. So it doesn't work straight away. So what do we do before starting medication? Again, this is not a detailed lecture about treatment, and none of you are going to go off and treat people as a result of it. You know, details of treatment are really a matter for another lecture. But what do I do before starting treatment? Well, first of all, is the diagnostic assessment. Then I review mental health comorbidities. So I look at depression, anxiety, substance misuse, risk assessment for substance misuse and drug diversion. So if somebody uses a lot of recreational drugs, you wonder if they might sell some of the ADHD medication and just buy drugs in the black market. And for those people, I prescribe controlled release medications because there are no fun at all. You usually can't inject them. So there's controlled release versions of methylphenidate called Concerta, which you can't really inject. Well, you can inject it, but it won't do anything if you inject it. It needs to be metabolized in the bowels, in the stomach, in the gut for it to work. A review of physical health. So you have to look at people's physical health problems. So some people with cardiac problems, it can be unsafe to prescribe. So I do a review of cardiovascular risk factors, and then I work out if I need an ECG or not, or other investigations such as an echo. Again, I can give you more detail if people are interested in that. But that's what happens before I start prescribing. A thorough psychiatric history, review of psychiatric comorbidities, review of physical health to see if it's safe to prescribe medication, and looking at people's substance misuse histories. Okay, so what's the conclusions? So if you forget everything else I've said, just remember this. ADHD is a real psychiatric disorder. It can cause significant difficulties at work, social life, and education. It has many comorbidities. It's easy to diagnose. It's much easier to diagnose than schizophrenia. and it's easy to treat. It's much easier to treat than depression or other things that psychiatrists treat. And it's very rewarding because patients come back to you and say you've changed their lives. And that's great. That's where I get up in the morning. So there we are. I'm now going to stop screen sharing. I'm going to put my camera on. I don't know if you guys want to put your cameras on so I can see. If you've got cameras, please put them on so I can see you, and I'm happy to take questions, either on the chat, or you can ask questions.
So I highly encourage everyone to show up and wave or smile to us. And we have questions on the chat. So, is pharmacotherapy more effective than psychological intervention, psychotherapy, both short and long term? By long term, I mean few years after initial diagnosis.
Well, that's the evidence the problem with pharmacotherapy is that people have to continue taking the medication for as long as they want their effects. When you stop the medication, it stops working. But I've got many patients take the medications for years and years. Some people decide that their life changes and they no longer need the medication because they're in a different environment, they have a different sort of a job. But the evidence is that it's more effective, yes.
And do we need to switch those medication on, or can we go on one medication a few years? Or
well, generally speaking, once you find effective medication, people can stay on it. Sometimes you do switch. Some people decide they want to try a different medication, but generally speaking, if it works, then people stay on it. When you start treatment of a newly diagnosed adult ADHD patient, which drug would you start with, says Sophie. I usually start with Elvance, actually. So Elvance is a long-acting dexamphetamine. It's the longest-acting medication that we have. Which is only 10 to 12 hours, so it's not very long-acting. But if you give somebody immediate release stimulant, it only is there for 2 or 3 hours. People have to take it several times a day, and levels go up and down, and people become anxious whenever the level drops. Whereas with Elvance, it seems to be you don't get this end of dose anxiety. It doesn't work for everyone, and these medications can suppress your appetite, they cause sleep difficulties. So sometimes I end up switching to immediate release medication. If it suppresses your appetite, for example, if you give somebody medication that acts for 2 or 3 hours, they can eat at the end of each dose and take the next dose. And quite often people end up having a combination of slow release medication to take first thing in the morning, and then towards the evening they have a booster of immediate release if you want to come on working in the evening. But so Elvance, I don't know what it's called in Poland. In some countries it's called Vyvanse. In the US, the most popular medication is Adderall, but we don't have Adderall in Europe. We certainly don't have Adderall in the UK. I think we don't have Adderall in Poland either, because the company hasn't licensed it in Europe. So it's got an American license, but not a European license. Concerta XL is an extended release form of methylphenidate. It's a bit shorter acting than Elvance, but still about 8 hours or so. And that's quite good as well. So that's a good thing to start. So you could really either start Elvance or Concerta. I personally have a preference for Concerta. I personally have a preference for Elvance, but you could do either.
Okay, we have another question. Is it possible that ADHD medications, by increasing dopamine levels, would decrease serotonin levels and cause apathy and depressive symptoms?
It's not what we see, okay? What we see is the opposite, that people with ADHD end up being less depressed for the reasons which are outlined. So we see the exact opposite. The treatment makes people less depressed. So it may be theoretically possible, but that's what we see in practice is the opposite, in fact.
Okay, so I highly encourage you to write questions if you have more, because we have just
If anyone wants to put the microphone on and ask a question in Polish, I can understand Polish well enough to answer the question in English. So if that's easier for people, please ask.
I was just wondering, in which patients and when would you recommend like additional treatment like psychotherapy as well to?
Right, so patients who don't tolerate medication, you get some people who have terrible side effects, and some people there's some people who are very anxious about the idea of medication. So if the medication either doesn't work or has an acceptable side effects, then those are the people where you've got nothing else to do but psychotherapy. And some people are very keen on psychotherapy. They have a worldview where they really prefer psychotherapy. They don't want the idea of medication. I don't put chemicals into my body. They are the kind of person where I would strongly recommend psychotherapy.
Because I've heard that in Poland you're obliged to do psychotherapy as well as medication. Have you heard anything about it?
I'm afraid I'm not very good about ADHD treatment in Poland. I've not discussed with any Polish psychiatrists, but I suspect that the culture in Poland is a bit different in that respect. And I mean, how easy is it to get hold? How often do people diagnose ADHD in Poland? Perhaps you can tell me. How often do you see it?
I think it's my personal opinion that not often, and I've never met anyone who diagnosed with adult ADHD. Sometimes in children, but adult ADHD it's not being commonly discussed, and even among the doctors, it's not popular, in my opinion.
You see, I know a lot of doctors with ADHD that I treat. Medical students with ADHD. But I think the attitude to amphetamines in Poland is probably a bit different, isn't it? Is there a political problem with prescribing amphetamines?
Yes, that may be one of the causes in Poland.
No, I appreciate that. I think somebody said amphetamine is not available in Poland. Methylphenidate is, okay. So if methylphenidate is available, you can prescribe Ritalin, you can prescribe Concerta XL, these are all methylphenidate drugs. But dexamphetamine is not available, that's helpful, thank you.
Okay, so are there any more questions from the public? Someone wants to join you?
But to be honest, methylphenidate is every bit as good. So, I don't think it's a huge loss that you can't prescribe dexamphetamine. It's pretty similar.
Okay, so I have a question, kind of a different from those on the chat. Do you have one advice that you would give like to young doctors who wants to follow the psychiatry? Like I know it's like a broad topic, but maybe some story or some something that that you would say to a younger self starting in psychiatry?
Well, I took a while to get into psychiatry, actually. So I finished medical school in 1984, and I started doing training in psychiatry in 1989. I did loads of other things. I did pediatrics, I trained as a GP, I trained as a physician, and I really didn't enjoy any of those things. I was actually thinking of quitting medicine, and in England at that time, there were a lot of people working in the financial services industry, earning a lot more money, and I was very jealous of these people. I didn't enjoy my job, and I thought, well, why am I doing this? And as soon as I started doing psychiatry, I started having fun. I actually got to enjoy going to work, and now I'm at the end of my career, and I still enjoy going to work. I quite like seeing patients. I saw 2 or 3 patients today. That actually quite enjoyed seeing. And so I think you should only do, I think psychiatry is a way of using your personality, because it's not a very technical specialty. But I think really you need to look at what you're good at. So, so I think, I'm not against surgeons. I mean, I'm a completely clumsy person, so I couldn't operate on anybody. I can't do DIY, and it just wouldn't work for me. But if you're very good at surgery, then that's a brilliant specialty for you. So you have to look at what you actually enjoy doing. So to me, do psychiatry if you enjoy it, and if you enjoy using your personality in your work, because in psychiatry, who you are makes a huge difference. So that's what I would say. But I think you've really got to know that you want to do it. But I think also it's a relatively less popular specialty, which means that it'll be quite a bit easier to find work, perhaps. But I don't know what the situation in Poland is with psychiatry, because we need more and more psychiatrists here in the UK. And so I would say, see if you enjoy it, give it a go. But you have to use your personality, and that's a very important thing.
Thank you for the beautiful answer. In Poland, I have the feeling that a lot of my friends want to follow psychiatry. So maybe we'll have more psychiatrists. And in the meantime, two questions on the chat appeared. So one, how often does ADHD co-occur with borderline personality disorder? Is it hard to diagnose as the symptoms are very similar?
Yeah, that's a fantastic question, one of my favorites. So I think the symptoms are very similar, and it depends on who you ask. I think that a lot of people with borderline personality disorder might have ADHD as well. And if you treat them, you might improve the borderline personality disorder. But the kind of psychiatrists who specialize in borderline personality disorder have a completely different approach. They're not really interested in pharmacology or dopamine. They're interested in psychotherapy. So I have a lot of patients with ADHD for whom I suggest a kind of skills training you might use in a borderline patient. And I had a colleague who worked in a borderline personality disorder clinic who was an expert in ADHD, and he used to prescribe a lot of ADHD medication to his borderline patients. I have to say, in my experience, people who present as borderline patients didn't really benefit a great deal from ADHD medication. So I think there are distinct disorders with maybe some features in common. The research shows that it's about 20% of borderline patients meet the criteria for ADHD. Okay, but I think a lot more research needs to be done on this for us to have a clear answer. I know my answer is a bit vague, but I'm aware that the symptoms overlap, so that's a very good question. Now, can ADHD medications boost performance in individuals who not have ADHD? Okay, so the answer is absolutely yes. So they'll boost performance in anyone, and that's why I spend 75% of this talk talking about the diagnostic assessment, because I'm a doctor. I do not prescribe medication to boost people's performance. That's not what I do. I'm interested in treating disease. So if you meet the criteria and you have impairment, you have a disease that needs treating. If you just want to do a little bit better at school or at university or in your job, then you don't have an illness, and I don't prescribe medications for you, because that's not, to me, that's not something I'm particularly interested in doing as a doctor. And that is the approach in the UK. So in the UK, it would be considered unethical to prescribe stimulants as a performance enhancer. That's why I very carefully document why I think someone's got ADHD in my diagnostic assessment before I prescribe. I think I would get into difficulties in the UK if I use it as a performance enhancer, and I wouldn't want to do it really, because I think medications have adverse effects. all medications have adverse effects, and you can't justify that just to enhance performance. And I suspect the answer in Poland would be even more so, wouldn't it?
Like, actually, if I may add something to that topic, when I was in high school, I had a friend from California who was an Adderall, and it was like very popular in his high school that he would basically sell Adderall to his colleagues to boost their performance. And actually, oh, sorry.
Go on. I'm listening.
Yeah, actually, we had one time, because like when I was in high school, I wanted to study in the US, and I asked him some questions about SATs, and I told him, man, I'm very anxious about it. What should I do? And he told me, yeah, like study, chill out the night before, and take some Adderall, and you'll be good to go. So that was really popular with him and with his colleagues, apparently.
Yeah, I mean, there is a whole body of research on black market in ADHD stimulants, and we know that happens at our universities. And modafinil is a particular drug which people get buy online in the UK and used to boost performance. So it's not, it's not prescribed by doctors, but we know it does happen, and that's happening in our universities as well.
Okay, so I think we have no more questions. So if I'm mistaken, maybe someone will interrupt.
I would like to ask one question, because I'm curious about patients' reactions to diagnosis. Are they surprised? Do they think that it's only a child's thing, or are they suspecting it before getting a diagnosis?
Okay, that's a fantastic question. So let me try and answer it. So most patients who come to see me have actually thought about this for a long time. They've been online, they've read about it, and they come because they think they've got ADHD. So most people are very relieved and very happy to get a diagnosis. There are some patients who were very upset that it wasn't diagnosed before. So I might see somebody in their 30s who would say, gosh, if I they always have like a bereavement reaction. What would my life have been if it was picked up earlier? Why wasn't it picked up earlier? I could have done this, that, and the other, and now my life is ruined because it's picked up so late. I usually say to these people, well, look, you've got most of your life ahead of you. If you're 30, you're very likely to live to 100 these days. And therefore, you're right at the beginning, and things can change. And I try and convince people that, that picking it up late is better than never picking it up. And interestingly enough, the people who complain, it's if I don't make the diagnosis. So occasionally you see people who clearly haven't got ADHD, and they get terribly upset. So if they see me privately, they sometimes don't pay. They sometimes will make a formal written complaint saying, I haven't heard them, I haven't listened to them, haven't done the assessment properly, why haven't I made the diagnosis? They've obviously got ADHD. To be honest, the people that I see have done so much research that it's quite unusual for me not to make a diagnosis. So I probably fail to make a diagnosis in about 10% of patients. Probably another 10% where I make a diagnosis where we decide that it's not worth treatment. The treatment isn't worthwhile, and I don't treat them. And some people, I just want to diagnose and no treatment. But the most common reaction is, well, why wasn't diagnosed earlier? My life would have been so much better if it was diagnosed earlier.
It must be very rewarding. I mean, I think it's very nice to diagnose someone and make him feel or feel happy, and not devastated that they got the diagnosis.
Yes, if it works, people say it transformed their lives. Not everybody says that. It doesn't always work. Some people don't get on with the medication. Some people are very anxious. So it's not perfect. And obviously, if it works, people go on the medication and stop seeing me because the family doctor will take over the prescribing. So the people who I see come back to me Usually where it doesn't work, unfortunately, they're the ones who keep coming back to see me.
Thank you for the answer.
Okay.
Okay, so I think that was a great meeting, and with those last questions, we can round up the whole webinar. And many thanks to Dr. Leon Revich, who was today's webinar guest. I think we all know much more about adult ADHD. Maybe some of us even diagnosed ourselves with adult ADHD, or now can diagnose our friends and family. So this knowledge will stay up forever with us. I hope so. So thank you for today, and thank you, Dr. Leon Revich, again. And we invite you to Poland one day, to Silesian University, to visit us.
Oh, please. I mean, I was saying that my biggest disappointment of this lecture was that I couldn't come, because it would be so much more fun to come and talk in Poland than doing it on Zoom. But there we are. That's the world we live in now. Because I gather that COVID is much more of a problem in Poland at the moment, and it's a very difficult situation. Is that right?
Yes, it is, and we have.
I'm very sorry to hear this.
Yes, but we hope we'll manage it, and that in few weeks the cases will drop, and the vaccination will go on, and everything will soon come back to kind of normal.
I hope so.
We hope so. Yes.
I wish you all the best in these very difficult circumstances, but I know that Poland has been quite. Well, we had the same thing here 6 weeks ago. It was terrible here, so it's just the way it is.
Mm-hmm. Yeah, sure. So thank you very much. We invite you to Poland when this all ends. Hope soon. And thank you all of you for participation, and thank you for all YouTube viewers who are watching it now later, this recording. So thank you again, and we'll not prolong it, and see you on the next webinar.
Thank you. Bye-bye. Thank you for asking me. Bye-bye.